you very much for that talk. And for the questions too, by the way. And to our online audience. Our next speaker is Dr. Annette Majnemer. She is an occupational therapist and professor at McGill University. She's on top of being this sort of part-time job, being Vice Dean of Education for the Faculty of Medicine. Her research at Montreal Children's Hospital focuses on early identification of children at high risk for disability and factors that influence outcomes for those with developmental disabilities. She currently leads Child Bright, which is another SPORE network, and that is focused on children with disabilities. She'll be talking to us today about what it takes to get patient-oriented research right. Dr. Majnemer? Thank you.
So thank you very much for this kind invitation, and I hope to share with you some of the lessons we're learning in a SPORE network that's focused on children with disabilities. So I just wanted to start with patient-centered care before I talk about patient-oriented research. So when I say patient-centered care, what comes to mind? Like, what are the words or phrases that come to mind to you? Just anyone in the any thoughts? Individualized. So very patient-centered, individualized. What else? Equality. Teamwork. So a collaboration, a partnership.
I don't agree with this, but I say people often think it's more expensive.
Sorry?
More expensive?
More expensive, possibly. So you're, in terms of more time, perhaps? So as a perception? Holistic. One more? Anything else? Okay, so let's see what I put down here. Okay, so the Institute of Medicine, the definition they provide for patient-centered care is providing care that is respectful of and responsive to the individual patient preferences, needs, and values, and ensuring that the patient values guide all clinical decisions. So what exactly does that really mean? So it's really about the collaboration, the coordination of care, really thinking about care from the perspective of the patient, that it's coordinated, organized, and there's a collaborative model to it. This idea of holistic, which was mentioned, looking at the whole person, not just the symptom. Presence of family members are encouraged, so really they feel the support of their own family members and that they can be there with them. Information is shared fully, so they can make informed decisions. And this idea of respecting their traditions and their values. So it's really about a team approach where the patient is part of that team and giving them, empowering them to be part of the decision-making process. So as an occupational therapist, we call this client-centered practice. So this was mentioned earlier this morning, the discomfort with the patient term, although I'm not so thrilled with client either, personally. But the same idea of collaboration and partnership, respect, recognition of the patient's or the client's experiences as being very important. Also, if we look at evidence-based practice, which is another an idea in clinical practice that's pushed, the patient's preferences and values also are part of this model. So it's not just about taking the best research evidence in the context of your clinical experiences, but also considering patient preferences and values in the decision-making to the best practices that you do. So it's certainly out there as an idea about this patient-centeredness or patient involvement or patient engagement in practice. So what about patient-oriented research? So this is a kind of a newer phenomenon, a newer terminology that we're hearing, and you heard this morning with the previous presentations, this concept of patient-oriented research. So the definition CIHR provides, one of them, is to help transform the role of the patient from a passive receptor of services to a proactive partner who helps shape health research and, as a result, health care. So it's really this proactive approach involving patients in the research process. So what does that really mean? So the concept is really involving patient partners in all aspects of doing the research, from generating what the research priorities will be to also the expectation is by involving them that we will improve patient outcomes that are most meaningful to patients, and that this will more likely result in an impact on healthcare services and the health of populations. So, when we have patients, we think of them as participants in research, as subjects or, enrolled in research, or maybe they'll observe part of research. But here, what it really is about is having them actually play in the game with us. So they're actually involved in all aspects of doing the research. Just as a short historical context to this, so this concept of public involvement in research began in the mid-90s in the National Institute of Health Research in the UK, putting forth these ideas of involving the public. I think more recently in 2003, it was reconfigured, the Involve program. PCORI, which you'll hear about today, and is more recent in the past decade, as it is in Canada. So in CIHR, when they were doing their strategic planning and their roadmap in around 2009, 2010, there was a lot of discussion about this approach. And there were some early documents coming through in just beyond 2010 about pushing this agenda of strategy for patient-oriented research. And we have several funding opportunities through the SPORE program. So CIHR's vision is that patients are active partners in health research that will lead to improved health outcomes and enhance healthcare system. So let's unpack that a little bit and look at some of these words a little bit more carefully. So the patient, the way it's defined by CIHR, is it's an overarching term. It isn't just the person who has the health condition, but it could involve others who really share in that experience of that health issue. So for example, for children with disabilities or children with cystic fibrosis, the parents are a very important patient partner because of their experience in that journey of their child's health condition. Involve really talks about patient partnership as doing the research with or by patient partners rather than about them or for them. So it's really a different attitude. It's an attitude shift in the way we do clinical research. It's really taking this, and this is what Deborah mentioned before, is this idea of seeing the expertise that patients can offer that is distinct from the expertise of clinicians and researchers. So it's really their lived experience with the condition and with their navigation of the healthcare system that we get expertise that we would not otherwise have in the thinking of the project that we want to do in research. So it really enhances innovative ideas or out-of-the-box thinking because there are variables, factors that we would not think about because we're just so used to thinking about it the way we think about it in what we read in the literature and what we do in practice. But the patients really bring a completely different lens that could influence some of the variables that we might consider, or even some of the questions that we might consider in clinical research. So they could be involved in generating or fine-tuning the research questions, in the study design, in how best to recruit subjects or participants, in data collection methods or developing the intervention, looking at the data and interpreting the results, and in dissemination. And dissemination, we use our usual ways of publishing and presenting at conferences with other people like us. but they will really think about other targets that could be interested in the results of the research. So whether it's patients or clinicians or policymakers or health administrators, and then thinking about what's the best way to package those results in a way that's going to be user-friendly. So they can provide perspectives that we don't always think about in knowledge translation. Patients can really add meaning to the relevance of the research to make sure we're addressing the needs of Canadians, not only the needs of researchers in terms of the quality and the relevance. And it's also a way, as was mentioned before, that it's, as taxpayers, we should all be involved and invested in the research that is being conducted with our money. So, and also a framework that is often used is the triple aim framework, where there is a focus on improving the health of the individual, but also looking at the healthcare system more broadly and trying to improve the way we conduct healthcare, and also looking at cost effectiveness issues. So in many patient-oriented research projects, it is looking at these triple aims of better health, better healthcare, better value. The guiding principles of the SPORE program, and there's a lot of really good information on the CRHR website if you're interested to look at this further, is the idea of inclusiveness, to make people feel they're really, it's the listening and feeling like they're being heard, that they're actually having an influence on the way you're doing research together, that you're supporting, that it's a supportive environment where you're building respect and trust, which takes time and is difficult. That there's education, so you need to educate patients about the lingo that you're using, the ways of doing research, the craziness of ethics, all the things that, that are part of the game that they're really unfamiliar with, so they don't feel uncomfortable not knowing what you're talking about. But we also need to train researchers about patient-oriented research approaches. And financial compensation is a very important issue and needs to be built into the research project budgets, absolutely, and we'll get back to that. So valuing expertise is a way of building respect, going in both directions. So patients also have to value the expertise of researchers and clinicians and all other members of the team. And the idea is that you're co-building or co-creating or co-designing the research project. So there was mentioned there are different frameworks out there of public participation, so I won't get into that, but they're helpful. Like what we aim for is at least to involve or to collaborate with patients in the project, so they're really engaged and there's a lot of back and forth discussion. There also is a term out there called citizen engagement. So aside from patients, there may be other knowledge users, so the people that will eventually use that research could be clinicians, could be health administrators who are developing budgets and determining resources. So there may be other citizens that are also very important to engage in the research project to get their voices as well. So it was mentioned that there is fair bit of evidence accumulating, even though this is, pretty much in the last decade as an emerging model in North America. There have been several, I'm just highlighting 2 review articles, and so it is feasible to do, like when you're committed to doing it, it works. There is a tendency to do a lot at the front end, as was mentioned. What best methods of engagement? We're still, there isn't a lot of studies in that respect, but there are many benefits that have been highlighted in the literature. To do it authentically takes time, and it definitely slows down the process, so you need to build that into your time frame of doing the research project, for sure. There isn't much in the way of measurement of engagement, which is still an area we need to contribute to and to really understand the engagement processes and what works well and what doesn't from the perspective of the researchers and from the patients. So I think this concept of tokenism is an important one. Some people feel they have to do it because it's the trend or it's a way of getting grant money to have a patient on the team. Some people feel they feel good about it, they feel it's right, but they're not really listening. Sometimes they want a patient in the team because they want that person to challenge another researcher on the team, so there are other vested interests. But these are not the right reasons to involve patients. Compensation is really important. As was stated, researchers and clinicians are paid during the day to do research, but if you're bringing patients in, they need to be paid for their time. And we've grappled with this a lot, and I'll mention the way we've tackled this in Child Bright. There's evidence that we use in building our research projects and developing our rationales and our methods, but what patients bring are their stories. So it's learning how to tease out the nuggets in the stories, which is different from using literature, to determine what are the important factors that can contribute to your research question, your methods, and your interpretations. But they can greatly enrich your understanding of your data, and it can also consider new variables you never would have thought to consider, or outcome measures that you never would have thought of that are much more meaningful for the patients. It is hard to do. It's really an effort. It's sometimes uncomfortable to do. There are challenges, but as was mentioned by Jeremy and Brian this morning, giving a voice to people in an authentic ways can be sometimes uncomfortable. Like sometimes you're not sure what to say, you don't agree with something. You have to work your way through it and show that you're trying, and that's really what helps you through that process. So why is there so much interest in patient-oriented research? Well, researchers follow the money. And so there has been a new injection of separate funds in CIHR, significant funds to support the SPORE initiative. So I think that has certainly ignited interest in several groups. But what has happened is as people are doing it, they are really seeing the value. And as training in different networks are occurring, more and more people are learning about it. And so there is a capacity building that's going on and a trickle effect in terms of it penetrating beyond those projects themselves to others who are interested and want to learn about it. So I think that's the real important thing, is that people are really learning how it can make such a difference. So let me tell you a little bit about our experience in Child Bright. So this is one of the 5 chronic disease networks that was funded about 3 years ago. I just want to acknowledge our executive team. So Frank Gavin is a father of a young adult with autism. Tonu Nguyen is our director of operations. Frank is the director of citizen engagement, so he heads up our citizen engagement program. Dan Goldowitz is a neurobiologist from UBC, and Steve Miller is a child neurologist and clinician scientist at SickKids. So when we were working on developing the project, so this is at the grant application phase, we thought disability would be an interesting chronic disease, childhood disability, to focus on. So we had 2 stakeholder sessions where we had youth and young adults with disability, parents, clinicians, policymakers, researchers come together and talk about all kinds of ideas about research. So with 2 of these engagements, face-to-face meetings, we had 25 at the first and then 55 at the next, with a lot of input from the parents and the youth in particular. We came up with some ideas of themes of research and possible projects. We then did a survey, an online survey, just by snowballing to different patients. So these were youth with disabilities and parents, and over close to 1,000 people responded within the week, validating that we were really in the right direction in terms of the areas that we wanted to focus on. We then built our teams to build our programs and to help us to put together this extensive application process. And we had to fundraise, because for these SPORE networks, you had to raise $12.5 million minimum to match the $12.5 million CHR was putting on the table to be able to apply. So that was a whole other partnership game that had to go on. So, yeah, like Imagine, we have our acronym. And so Child Right came about, and with really a diverse group of individuals across the country, different provinces, different stakeholder groups. And the fundraising, I just want to acknowledge our funding partners. We have 27 funding partners, mostly the Children's Hospital Foundations, who have been incredible in supporting our network. In the application, we had 15 PIs, 3 of which were parents, and 160 co-applicants, many organizations, and the funding partners. So it was a huge group invested in this application process. And we were very fortunate to get funded. So just to tell you a little bit about Child Right with a focus on the patient engagement piece. So our vision is to create brighter futures for children with developmental disabilities and their families across their life course by promoting healthy outcomes through optimizing brain development, creating novel interventions, and providing responsive and supportive services. Our target population of interest are children with disabilities. So these are children, for example, with autism, fetal alcohol spectrum disorders, cerebral palsy, specific language impairment, ADHD, learning disability. But we also are including children who are at high risk for disability, so premature infants, babies with congenital heart disease that require open heart surgery. An important other target are the families of the children. So we've seen that as the patient, the definition of patient, which extends to the parents and families as well. So this is, although a very broad group of chronic diseases, very heterogeneous, there are certain commonalities in terms of their needs. So we do adopt the triple aim framework where, in terms of the outcomes of our studies, we're interested in child health, we're interested in the healthcare system and improving it, and we're looking at cost-effective strategies. The programs within Child Right include a patient-oriented research program. So this means that the 12 projects, and now we actually have a 13th project, all must adopt a patient-oriented research approach, which we monitor very vigilantly. The last project that we just funded actually came from the First Nation communities in Ontario, where they had a concern about the Indigenous children who had neonatal abstinence syndrome due to fetal exposure to opioids. And they are worried about these children at school and how they're struggling in school. So this came from the community, and we're working with the community to develop a project. We also have patient-oriented research training, which is very important for researchers, for patients, for clinicians, for policymakers. A knowledge translation program, which is, again, involves all stakeholders in the process. And citizen engagement is really the glue in the middle that holds this all together in terms of really making sure we're engaging maximally the various citizens that are important in terms of their voice for our vision. We also have a data coordinating center based in Alberta with RedCap, and they provide expertise in terms of data architecture for multi-center studies and statistical support, and a health economics service given our interest in cost effectiveness. So we have health economic experts who are consulting our projects to look at measurement of this area. In terms of our research program, so the 3 themes that emerged that families really felt were important is they still felt an important need to look at optimizing brain development for healthy child development. There was a strong message of focusing on mental health, which is a very common comorbidity of children with disabilities, but often not paid attention to, and also the mental health of families, and trying to fix the healthcare system because they go from one wait list to another, very long periods of waiting. They feel every transition that their child is making is like they're falling off a cliff, where they just don't know where to go and what to do, and things just keep changing and evolving, and it's very, very challenging. So the Bright Beginnings of Brain and Developmental Outcomes, we have 6 projects. There are 4 projects around mental health and 3 around service delivery redesign, all using a coaching model. So if you're interested, in our website, we have the report to community, which goes in detail, 2 pages on each project to really describe them in detail. So I'm just giving you an example of one project that I am involved in as an example of how patients have completely influenced how we're doing this project. So in Bright Coaching, the problem that we're trying to address is that many children with disabilities do not have the disability obvious at birth. They have an uneventful pregnancy and delivery. Their early months, they're developing well, but then around between 18 months and 4 years, we're seeing developmental delays gradually emerge. And these are children with speech problems, motor problems, coordination problems, cognitive issues. They may develop attention deficit. Some have autism. Some have mild cerebral palsy. And so what happens is these parents, after discussing wait and see, they're referred to some center for diagnosis. They can wait a year or more for that diagnosis. Then they're put on another wait list for treatment, again, many, many months for the treatment. And it's just a period that's very, where parents feel helpless, where they don't know what to do, they don't know what's wrong, and what their role can be. So the Bright Coaching is really to address parents who are on the wait list for their first visit, so that as soon as they go onto a wait list for diagnosis for developmental delay, they can start this intervention. And so this is a telephone intervention with a coach. There's also learning materials online, so many, many resources depending on the interest of the parents that have all been vetted, as well as a peer support opportunity online with other parents like them. So we have parent advisors from where this project is a randomized trial across 4 provinces. We have 10 parents involved in an advisory panel. They have looked at our consent forms, which were not user-friendly, and they're all different from one center to another, so they were very helpful in making sure the language is understandable. We had a lot of discussion about the outcome measures we're using and how relevant they were to them, and also the sequence of assessments which are done online. Starting with the demographics, which we always start with demographics, they felt was very was stressful for them to respond to those questions first, and they said, that should come later in the bank of assessments to do. They want to know, why do you need to know things like my education and total family income? Once we explained it, they completely understood, but they said you need to put that in so that people understand why you're collecting this data. So they went through and made sure everything worked easily, was very user-friendly. We had 2 online platforms that we thought could be interesting to use. They rejected both of them for different reasons and helped us to find a third that was really a great resource. When we were thinking about the topics that the coach could discuss with parents, they were very, very instrumental in saying, I wish I knew this, I wish I knew that. These are all parents who have children with disabilities who are all under 10 years of age, so it's recent for them. So they were very helpful in developing the content. We then wanted to do a survey to a larger number of parents to make sure we're getting the right content. And we started with open-ended questions and then specific, because we wanted to first see what they thought. And they said everyone who sees that is not going to respond to the survey. They're going to delete it because it's too scary to have an open-ended question first. So it's things like that. They really helped us in designing a survey that people are more likely to complete, and we had 250 parents give us additional ideas about the intervention. They reviewed our manuals, they helped us with our platform in terms of the content, and even the script that we were using for recruitment, where the clinician first tries to recruit the families to give permission to get the name to the research team, they thought our script was terrible, that it would scare people away. So it's really, we're using them constantly back and forth, and this is just the beginning of the trial. So it's a constant, very important relationship. In terms of patient-oriented research training, we have webinars and face-to-face workshops that anybody can take. Some are undergraduate program. There is something that could be very interesting for people here in the room. The PORCH program is together with CCH-CSP, the Canadian Child Health Clinician Scientist Program. So it's a patient-oriented research curriculum in child health. So this is for any patient-oriented research related to children. And it's 20 minutes per module. There are 2 modules that will be coming out very soon, and it's meant for parents and for researchers to define what patient-oriented research is about. So it's a short investment of time to get a flavor for what patient-oriented research is. But if you join our newsletter, you could, our external newsletter, you could find out about various training that's going on, and you can certainly sign up. We also have a peer mentor for parents who are parent partners in our team, so they have mentorship on the process, because sometimes they have difficult situations that arise and they want some support. And we also have an innovation fund. In knowledge translation, we have a variety of products and tools that we're developing together with patient partners and policymakers. And importantly, we're measuring patient engagement. So we are looking at what's the engagement process like from the perspective of patients and from researchers. So in terms of citizen engagement, we do have a Citizen Engagement Council, which is made up of several parents, 2 youth with disabilities, a clinician, a researcher, someone from a child organization. And they really advise us constantly about various issues that come up with respect to patient engagement. Patients are represented on all our committees and our research projects, and we are now building a youth advisory panel across Canada that provides consultation to different projects. The strategies that we're using, so the compensation is really key. So we worked with our Citizen Engagement Council, so these are parents and youth predominantly, about how to compensate patients in research. And these guidelines are available on our website. They're constantly changing. It's really been an iterative process. What we landed on is that it should be an honorarium for the year rather than an hourly rate. And it's really to respect the commitment they're making, whether they're members of a committee or members of a research team, and we estimate what that commitment is, and we put an honorarium amount for these different activities. And certain activities require more time, and therefore the honorarium is larger. But there is the opportunity, if researchers say that this year these 3 patients really gave a lot more time than usual, then we make an adjustment to the honorarium for that year. We also include activities, like if they come to help present on a panel somewhere, they're paid not only to travel, but for their time. And so we have rates for that. We have rates for babysitting if they have to come to a meeting that helps to support that. So so it's an extensive document that's really gone through a lot of, like all our parents and youth have looked at this very carefully. And as new situations arise, we build it into our guidelines. The patient-oriented research training is an important process for people to know how to do this. We have a matching tool, so although we have many patients already involved in our committees and research projects, we have many parents who are wanting to be part of our network. So they fill out a matching tool of their profile, their interests or expertise that they could offer, a little bit about their child's age and type of disability, and people keep going back to the matching tool for let's say we wanted someone to look at a venue to make sure it was appropriate for a person with disability, so we took a young adult with a disability with us to look at the venue from the matching tool. Or when we're developing products for the public, there are people with editing experience or writing experience, and we ask them if they'd be interested to review some of our documents to provide the lens of a patient on that. So we're constantly, researchers too, from projects projects, when they want additional parent input on some aspect of what they're doing, they can go to the matching tool. And we have close to 100 people now in that group. I mentioned the parent-peer mentor, and we're also tracking patient engagement in each project very closely. I don't expect you to read this, but just to say a point that was made earlier today is that not all patients want to engage fully as partners in research. It's not for everybody. But there are different levels of engagement, and they're all good. They're all helpful, and they're all important. So whether they just want to follow us on social media or attend a conference or participate on a webinar, that's great engagement. You know, that empowers them, and that helps us in terms of their input, their responses. They send questions to us. So it's not only engaging, you know, directly to the committees or to the research projects or leading a committee or leading an initiative, but it's also just raising awareness and participating in other ways that are also important. So that we mentioned some of these things already, and that we're looking at measuring levels of engagement, particularly trust and partnership. So just finally, you know, the point of these discussions is to kind of raise your awareness of what patient-oriented research is in child health. And ideally, my target would be achieved if some of you actually bought into this, were interested, wanted to learn more about it. So what can we do? Child Bright, we do have training products that are available to anyone. Most of the people who participate are actually not people from Child Bright. And the Porch online modules, which are short, will be coming out very soon. So if you join our newsletter, this is a way to be informed about what's going on and what you could participate in, and everything is free. If you're interested in the compensation scheme, you can look at our guidelines. PCORI has guidelines, others have guidelines as well, CIHR has guidelines. So it can help you in the development of your budgets for research to think about how to build this in. And we would certainly be happy if Cystic Fibrosis Canada, for example, wanted to develop a patient advisory panel for research, or a youth panel, or a matching tool. We would be very happy to participate in helping you in that regard. So just as a final take-home message, the authentic patient engagement is really about how you do it. And you know, providing the supports that you need, the education, the compensation, really trying to promote respect and trust between all members on the team, and really having a commitment to co-building the research project together. So it's really in the how that's really important. So my title was about getting the arrow on target and aiming for authentic patient engagement. I have to say that this is hard to do. Like I am learning as I go, and we are learning as we go. There have been bumps in the road. You know, as we're talking about it recently, there is one parent on the Citizen Engagement Council said, it's like there's comfort in discomfort. Like there are difficult challenges to it, but it means that it's real. Like if it was all perfect and lovely, it means that we're really not getting into the difficult stuff. So it is a hard thing to do, but I hope I've convinced you that it's worth it. Thank you. Questions? Questions, comments?
John Wallenberg, Cystic Fibrosis Canada. I was wondering if you could speak a little bit more about what you were saying about measuring patient engagement. Perhaps the tools, but more significantly, maybe the outcomes of what you're doing to measure the impact.
So the reason I mean, anecdotally, we know people finding it makes a difference, but we don't really know individually what people feel. So having standardized measures is a way of, you know, it's all anonymized except for stakeholder groups, so we can, and which project they're from we have as well. Because most of these projects are, the Bright Coaching is 35 people. Like these are huge teams. So it's really trying to capture, is it really a partnership? Do people feel they're listened to? Do they feel they've actually influenced the project in some ways? Also, the personal, like what a lot of patients feel, like what they get out of it is a lot of empowerment going forward. They feel more in control of things more generally because they felt that their experiences mattered, like they made a difference in a bigger way. And so learning through measurement really what the benefits are, and also where we see discrepancies. So if we see certain projects where we're not seeing that engagement level, we try to understand, well, what are the strategies used in some projects versus others? What seems to be the key ingredients to successful engagement? So it's really as a learning, because it's a new field, to understand what the benefits really are, but also how we can do better. And we do hope to do a qualitative piece of individual interviews to really enrich our understanding of the good and the bad, so that we can learn from it.
Thank you. That was a really great comprehensive talk, and you're doing some fantastic work. We should all model ourselves after Childbright. Can you talk a little bit about, like, in the SPORE networks, it might be useful, there's sort of cross discussions as
yes.
well. And do you have any comments or insights about what really good things, you're doing that maybe other people aren't doing that you might recommend to be adopted as good practices? Like, where are the real bright stars? You've got so many good things going on. What are the best ones?
It's fun, but it's hard. What the SPORE networks, we have had 2 SPORE summits. That's where I saw Jeremy, and I thought he would be amazing for this conference. So we've had a couple of meetings, the SPORE chronic disease networks, because there are actually 7. There were 2 that were funded first, and then the 5 chronic disease networks. And there are some other networks that are also funded in some way, larger projects. So we have had a couple of meetings with CIHR to look at common issues, common needs, and measurement has come up as an important one. And as many of you may know, that each province has a SPORE support unit, and the way they play out in each province is quite different. But the Quebec one has had an interest in measurement, which has been advantageous for us, I think. But what they're doing is they're mobilizing the SPORE networks to help feed into their work, that we build a tool, not only a toolbox of measures, but a framework to consider of how to do patient engagement and the measurement piece around patient engagement. So that's something that's being done across the networks. We're looking at training as well, because we don't want to have redundancies, so we certainly share tools, products. What we're learning with a youth panel is helpful for other networks that have mostly a focus on adults, but they do have some children with their condition. So we are constantly talking to each other in informal ways, and CHR is trying to facilitate that for sure. But we need to mobilize and capitalize on this expertise that's building, so that we really harness it. I agree with that. Any questions? Okay. Lunchtime.
I think we might be seeing a bit of lethargy set in because people are, glucose levels have dropped. Thank you, Annette, very much.